Welcome to the Arizona Sunset Podcast. Our goal is to seek senior solutions for aging problems. Now your host, Justin Owens.
Okay, this is the Arizona Sunset Podcast. My name is Justin Owens, and I am here at the home office, corporate empire of Stokes Home Health. And we are talking to the owner today. Would you like to introduce yourselves and how you came to found this company?
Yes, my name is Rebecca Stokes. I am a registered nurse, and the reason I started this company was to be able to give the elderly and people with disabilities the care that I feel that I would want my own family to receive. And so that's why I started this. I saw demand in the hospital and in different nursing homes where they needed care to keep them out of the hospital and healthy.
Hi, my name is Anthony Jensen. I am the administrator here at Stokes Home Healthcare. I joined Rebecca on this because I saw her passion in wanting to take care of people in a way that she would want her own family taken care of that wasn't being provided. And so when she presented me with the idea of starting a home health care company, I said, yep, let's do it.
And when was that? When was the company founded?
So 2016, we started thinking about doing it in 2015. Due to some life events that happened, I ended up putting that off. Actually, we started 2012, but due to life events, I had to put that off for a few years, and then I came back to Anthony back in 2015, 2016, and we decided to move forward with the company.
Okay, great.
Mm-hmm. And so the last name, as far as Stokes goes, that's my last name, so I decided to carry that and to be able to bring that into our company, because I feel that if I have my name in the company, I'm going to make sure that our company represents me and what I want, because it is my name and I take a lot of value into that. So,
does that give you more motivation, or you're tied to it, right? So whenever an employee or someone goes out to represent your company, they're representing not just the company but you, your name's on all over everything.
Correct. And that's why I did. Before we started out, we were Valley Home Health Care, and then I did a DBA to Stokes Home Health, and we also have a hospice. But I switched to Stokes because of, this is a valley, there's a lot of valleys. And I wanted them to know me for who I was and for who our company represented. And so I switched it from the Valley Home Health Care to Stokes Home Health, because you're right, it does. I mean, I take a lot of value in who I am and the care I provide. And so changing that really helped us to be able to deliver the kind of care we wanted and to be able to have our name on the line.
Mm-hmm. Yeah, our care is very personalized, and so to provide that level of personalization, having Rebecca's name on the company kind of reinforces the fact that this is personal for us. This isn't just a business, it's about taking care of people. And so having her name on it is what lets people know that we're serious.
So one thing I will say of why I chose Stokes, and this is just a briefing, I don't want to go into any history. My husband that passed away was a doctor. I'm a nurse. So when I said we started talking about in 2012, he died in a car accident August 13th of 2013. And we planned on doing this before he passed. And I met my husband now, and he was able to help me carry out my passion that I started. And so he helped me get done what I want to do and to be able to fulfill what we started. And so that's why it means a lot to me, because I mean, technically this business was started by a doctor and a nurse, and then my husband, Anthony, which he also came from administrative, he was in Humana. So it just meant a lot to us. So that's why we kind of carried the name out.
How do you go about providing that personalized service? I think you both had mentioned that. That's one of the things that you pride yourself on, that you really focus on here. And with your clients, patients, whatever you call them, how do you deliver that?
Well, I think a lot of that gets delivered, especially when Rebecca and I go out on a start of care. So normally that first visit out to that patient, there's a lot of times when Rebecca and I are the ones that go out. And it's not just for us, it's not just a visit to get paperwork signed and check their vitals and make sure their wound is okay, but it's to get to know them and to get to know the family, the caregivers that are around them too, because there's a lot of times when we may be meeting with one patient, say the husband of a married couple. This just happened last week. Our patient was the husband, and when we got there, he spoke to us about how he was concerned about his wife. And so we spent the time to actually go over some information on his wife too, and talked about, did she need help also, and just made sure she was doing okay. And in fact, she had a really high pulse. And so that was something that, we checked on. And so it's that level of detail that we go into. They're not just a patient to us. It's someone that we want to take care of. And it's not just taking care of them, it's taking care of the people around them too. So as a unit, they can be more healthy.
From your website, I saw that you guys cover all of Maricopa County and Pinal County. Do you guys extend that far?
Currently, yes, we are covering Maricopa and Pinal County. We are looking at possibly an expansion up towards the
Payson Pine.
Payson Pine area.
Is that Gila County, I think?
I think it's Gila County, yeah. Mm-hmm.
Just because of the demand. They don't have, because you'll see, even if you drive up to like Pine and Payson, you'll see hospice companies, which is good and well because there is a reason for hospice, but we want to have people live their life the best that they can, and with whatever condition that has happened gradually over time. It doesn't mean that they were negligent or whatever. As we age, there's certain things that happen. And so when we went up there, we've been kind of looking at the area because they've been trying to get us up there. I saw 2 hospice companies. I saw an oxygen company, and I did not see any home health care companies. And so they're really lacking that, especially when people ask, oh, well, you work with insurance. We don't have that here. So a lot of people, it's just letting them know what they do have available and having them utilize their benefits for working. And that's what it is you worked, that's how you get Medicare. So we just want to make sure that people utilize what they have, and a lot of them don't know that they can get this care.
Have you had experiences with families where, because you offer both in-home health and the hospice, that it's an easier transition, that as in-home health, you're able to say, hey, the cancer's back, you're not wanting to go through the chemo again or whatever it is, whatever situation, it's an easier transition as opposed to, okay, we do home health, and then maybe refer, or maybe not, maybe the people aren't even, aware, or if they're not, in touch with these people or know their situation, they won't be able to transition them. Does that work better when it's all under one umbrella of Stokes?
Yes, so technically we're supposed to give them options, and we always will give them 3 options. So yes, it does work better because yes, we might say, okay, well, we have hospice and we have home health, and they're already under the impression that they're not going to go anywhere. But we give them the 3 because it is mandated by Medicare, and we want them to have other avenues to go if they need that be. But it is an easier transition because if you're just hospice and you're coming in there saying, okay, well, you're going to die here soon, it's like almost like, the death guy knocking at your door. We're here to, to help you die in peace. Now, they already trust us. They already know us. They know what we do and what we provide. And that just makes it so the transition it's just like kids, they transition from 2nd grade to 3rd grade. It's an easy transition. They know you, they trust you, and they know that you have their best interest in mind. And so I can honestly say that I wish we had more providers.
Yeah, absolutely.
More qualified providers, because we go through the vetting process to make sure these providers know what to do and what needs to happen. But yes, it definitely makes the transition from home health to hospice easy. They understand and they know.
Yeah, we provide home health aides, CNAs, that quite frankly, a lot of their job is doing very personal care for people. They're in there for 2, 3, 4 hours at a time, and they're cleaning their house, they're helping them with their hygiene, they're getting them dressed, they're doing their laundry. And so, when you're spending that much time with someone doing these very personal things for them, you really get to know people. And so when people do need to transition from home health to hospice, being able to give them that opportunity of saying, well, this same person, these same caregivers are going to continue with you when you move to hospice, it's a big relief for some people, because people they don't want new people coming into their house. Some people are very private, and once they let someone in, they're not looking to let anyone else in. So there is a big
trust factor.
Yeah, there's a big trust factor there, and so once you gain that trust, people sometimes don't want to do anything against that. So there are definite benefits to having both, because people can transition back and forth either way.
Well, and not having gone through it with the Medicare and qualifying and getting to the right doctors to get home health or to get hospice, like having helped family members in the past, it is kind of a pain if you haven't done it before. Like, it's intimidating. That's why people let their loved ones go too long before getting home health or before getting hospice, just because they don't know where to start, they don't know who to call, they don't know that whole process, because it can be a lot of hurdles to jump through to get these things approved.
Oh, absolutely. And that's where, when we come in, we're working with Medicare, we're working with the different insurance companies also. We know the process. And so, again, to that level of personalized care, we're not just going there and saying, well, okay, you've only been approved for a skilled nursing visits and that's it. And so if we see that someone may have some muscle weakness, we may recommend that they get physical therapy or occupational therapy too, and it's nothing that they really need to do on their part. It's no extra burden on them. We'll take on that responsibility of getting the orders to the doctor to make sure that the doctor's okay with that therapy happening. We'll get the approvals from the insurance company if needed. And so to them, it's completely seamless. We're doing all that legwork for them to try and make it as easy as possible.
That's great. You had mentioned that there was a shortage in providers. Is there a specific discipline, or I know you guys cover a lot. I printed out, I'll just go ahead and read them from the website. You had skilled nursing, home health assistance, physical therapy, occupational therapy, wound care, speech therapy, medication management, IV services, disease management and education, and then hospice services, and there was a bunch more into that.
So I would say probably the biggest thing that we're currently is to find enough qualified registered nurses, because we want to make sure that we have a nurse that's able to go, because they're doing a lot of stuff without someone over their shoulder. So they're going into this house and they're assessing not just the patient but also the living condition. Now, is this safe? Is it safe for us to go in there, or are we putting ourselves in danger? Has the patient fallen? I mean, you can find so many different things where we'll get phone calls saying, go out to this patient, and they've never had any home health services. We've had some people that are in their 90s living alone and can't even, they're just withering away. And so we go over there, and it's how we can take them from not being able to ambulate, not walking at all, to walking, taking care of themselves. And sometimes they just need that extra rehab or that extra push to remind someone, oh, well, you need to take your blood pressure medication, or we need to set up your meds, because a lot of times as they age, their eyes go bad. So they might not be able to tell, did I take this med or did I not? And so we kind of take that away from them. We have a med set. We put all their medications together, and now they're there for them. So we're not worrying about, are they taking them, are they not? And if they need a little bit of extra assistance, we'll provide more as needed. So
is that what the for skilled nursing, or the RN would come in and do the medication management? So were they going to put them in each days for the tray or whatever? And, okay. So the senior's just opening it. And
correct, and popping it in their mouth, and that's all they have to do. And so nursing, the reason why nursing, I would say, is the biggest one where we're short is because nurses do so much. They might do anything to, respiratory therapy, diabetic management, wound care, medication management, cardiopulmonary assessment. I mean, they're doing everything as far as, and they'll even go into the home to do injections if they need injections, if they need their lab drawn, if they need infusions. So if someone's getting sent home and they're going to be on infusions, you get phone calls, I don't know what to do. They're sending me all these IVs. How can they do their own IVs?
Right.
So we're going to have someone there. I mean, we'll be there at 11 o'clock. If they're getting discharged at 7, their next dose is for 11. We're going to be there to keep them on their regimen. So that's why I think nursing is probably the biggest shortage we have.
Yeah, and home health is probably a little different than most of the other fields for nursing, because there's not as much structure to it. So like Rebecca was saying, you may get a call at 11 o'clock at night. You may get a call at 6 o'clock in the morning. Where in other nursing roles, you've got a set time. You're at the hospital, for example, from this time to this time. You're working in that time, and during that time, you have a very structured schedule. You know who you're going to see, how long you're going to see them for. With home health, it doesn't work that way. The schedule is much more fluid, and a patient you may go see that you think is going to take 30 minutes might take an hour and a half, 2 hours, because all of a sudden you just found out that they had a fall an hour before you got there, and so you've got to deal with that. Or their blood pressure may be too high at the time, and you can't just say, well, my half an hour is up, I got to go. You have to stay with them and make sure that they're okay. or wait, if something should happen, wait for the ambulance to arrive and make sure that they're taken care of. And so there's much more of ambiguity when it comes to home health nursing than, say, nursing in a facility or a hospital.
When someone is being discharged from hospital or rehab or a center like that, what do you recommend for people who are planning to go home? At what point would they reach out to home health? Because I imagine the transition is critical. Because if it's not done right, they're going to be missing medication. They're going to be just thrown out of whack, not only transitioning back home, but then, with the medication off, it could be disastrous. So how would someone who has a loved one going, being discharged and going back to their home, how would they go about getting everything set up?
So I always say knowledge is key. A lot of people don't know that this is out there. So I would say anytime they go into the hospital and they have weakness or they know they're going to be discharged with medications and it's something new, to start that discharge planning as soon as you get into the facility. So if it's a long-term care facility, they should start that planning before they get discharged, because usually insurance dictates if they're going to be there 7 days or 14 days. And they know upon when they're admitted into whatever facility. So if we're able to get that started from when they first arrive, we have everything done, and then when they get home, things are taken care of. So things are kind of transferred home with them. So we already know what their diagnoses are. What are we treating them for? If it's a HMO, we've already gotten the insurance authorization to treat them, so there's not going to be out of pocket expenses for us to go in there. And so as soon as they get intaked into a skilled nursing facility, or if the hospital knows they're going to need to get home health, as soon as we can get that started, the better it's going to be. That way there's there's continuity in care and things aren't falling off, because they say rehospitalization is most likely going to happen the first 30 days after they've been discharged. So what we like to do is once they're discharged, we need to keep an extra eye on them. They just went in for if they had a heart attack or if they had a stroke or if they had something happen. The insurance usually gives you 60 days. And so they want to see that we're rehabbing them and that they're improving. And so they need to see a real improvement. But if we can get that started from before they're discharged, everything is there. They get home and a nurse is there waiting for them to get them in there. We've even had them when they've had to be transferred on stretchers. The nurse is there ready to set up the feeding tube. And so the sooner the better.
Would you go do the assessment at the facility then where they're at?
Sometimes we will. So
or just get their charts? Or?
If it's more of a higher acuity patient and we know that there's going to be more stuff, like if they're going home on feeding tubes, if they're going home on IVs, we'll go get some of that stuff at the hospital. So we already know. And the thing that's good with us is we'll set up that. We'll work with the caseworker from the hospital and set up all the medication to arrive at a proper time. If they can't get it at a certain time, then we'll have it delivered here so they get their medication on time. So we can work on that, and we can work through the companies to make sure that they have everything set up before they get home.
Yep. I would say from a caregiver point of view, ask questions. Don't always assume that the hospital or the facility that your loved one is being discharged from, that they took care of everything. Always ask questions. Make sure that you're good with everything that's happening, because a lot of the times we're all human. People will forget. And so if you're confident as a caregiver in everything that's going to happen and you know everything is set up, that's going to go a long way in making sure that that person is cared for.
My grandfather was recently hospitalized, and my mom and aunts took turns sitting with him and advocating for him, because this happens, right? You think, oh, he's fine, he's got 24-hour care, but no, things happen, and they were asking, when is he getting discharged? What's going on? He went from rehab back to the ER, and then he came back, and then there's a lot going on. So we were trying to always stay a step ahead, so we knew where, what to get ready for him once he's discharged finally.
And that's nice, because that's where we can too. And I've done this many times where the patients are like, "Can you come here and can you walk me through the process?" And we'll do that. We have medical social workers. We have, we'll go do that sometimes just because the hospitals like to talk to you and find out what's going on. But we can advocate for our patients. And so we already know. And usually when they know that they're going to a company, it's easier to get those orders done because we kind of help them and guide them. Because some of the people too, if they haven't had experience, they don't know how to get the discharge orders done to have that happen.
Mm-hmm. Yeah, so that does happen.
Yeah. So, we advocate, and that's where once you get our company, and that's something that's different from us, is once you get us, we're your advocates. If you need help, let's say that someone's living alone and they're losing weight steadily, and why? Can they not make food now? Okay, so let's get Meals on Wheels or some other program to deliver them meals so they have food. And so we'll do stuff, and we have the phone numbers, we have the contacts to ensure that these people are taken care of. So
beyond just the medical and
we don't just do medical. We take care of that. We take care of the person as a whole. So if they're lacking something, like if they need long-term care, so there's a lot of patients where if they fall into a certain category, they qualify for long-term care, which equates to about 30 to 40 hours of paid caregivers a week. And that gives them the extra added effort. And our social worker will actually walk them, come give them the packet and tell them what you need to do. Give them say, once you're done with this, we just need to get mailed out, and someone will come to your home and get you qualified for this All-Tex. So that really takes a little bit of it away from the family, and that makes them so they're not feeling overwhelmed. So,
are most people coming in with insurance, Medicare, All-Tex? Like, how does that break down for your patients?
I would say really overall it's probably about a 50-50 split, because we joke around and say we don't discriminate by age. And so we've had patients as young as 2 weeks.
Babies.
Yeah, or even Euro. Yeah, and as old as 96. So obviously your Medicare mostly is going to be 65 and above. So under that age you're mostly dealing with regular insurances. So for us, we've got a good mix of insurance, some self-pay, some Medicare.
Okay. Mm-hmm. As far as Medicare goes, I know there's various plans, different providers, et cetera. Is there any type of rule of thumb, or in general, services covered by Medicare depending on the needs of the person?
Yes. So if they're, tell me if I'm answering this right, but if they're disabled, so let's say if they're 22 years old and they've been qualified with some type of disability and they're getting Medicare, now they fall under the same category as someone that's 65 and over. They get those same benefits that roll with them. With that, as far as the other ones, there's different insurances. There's PPO, which can be a PPO, Blue Cross Blue Shield Advantage Plan. An Advantage Plan PPO means that they're Medicare, but Blue Cross Blue Shield is overseeing that plan. So instead of just going straight to Medicare, it's Blue Cross Blue Shield that we're going to. As far as Medicare benefits, you're going to get more benefits if you stay strictly Medicare primary, and then use one of the secondaries for the copays, because a lot of times you get the hospitalizations or other stuff. But if you're straight Medicare, they pay home health at 100%. Some of the other ones might only do 80%.
Okay.
So it makes a big difference on their pocketbooks.
There's also a big difference too, because Medicare doesn't require authorizations, where the insurance company, so let's say we're going to go into a patient's house and we're going to provide skilled nursing and physical therapy. Mm-hmm. So if they happen to have an insurance, then we need to apply for authorization from that insurance company to perform those visits. Sometimes the answer is no, or sometimes the answer is very limited. I mean,
or would there be a delay at least in coming back with the answer?
Yeah,
they need it. You have to leave until you can say. They say yes, then you go back at best case scenario, right?
And we've run into that situation quite often, where insurance companies, we get a patient discharged to us that is wound care, for example, and needs to be cared for 3-4 times a week. And when we go to apply for authorization from the insurance company, they say, well, authorization can take up to 14 days. And for us, this patient doesn't have 14 days, and so you almost have to stress upon them, it sounds bad, you almost have to stress upon them the dollar value to them, and saying, well, if I don't get off in the next 24 hours, more than likely this patient is going to go back into the hospital. Is that what you really want to see have happen? And once you present it to them like that, they're usually like, oh, well, we'll fast track this, or we'll make this a priority, to just understand that. So yes, there are a lot of times when care is delayed.
Can I interrupt you? Or if the authorization process, if it's imperative that we see them, like if it's wound care, they have a wound vac or something that's huge, a lot of times as a company we'll just say, okay, yep, we're gonna take this one as a risk for us, and we're gonna go out there and we're gonna see them. Why? Because ethically, I can't sit there and say, okay, I know you have this wound that needs to be fixed, and I'm just going to leave you alone for 14 days and hope for the best.
Right.
And so when it's something like that, we as a company take that upon ourselves to say, okay, you know what, worst case scenario, we cannot get paid for 2 weeks of care. Does that hurt? Yes. But at the same time, too, ethically, we're doing what is right for our patient, because we're not just kind of deserting them and saying, well, sorry, we don't have off, have a good day.
And you're not required as a hospital to like care for someone who's there, right? Like if someone can't pay, then they still have to take care of them. But as home health, you're not under that same obligation, are you?
No.
Okay.
No. But like I said, we
It
do
is the
that
right thing to do.
sometimes because
Right.
we look at the situation and we see what's going on and we know what's going to happen. When we run into that, we try to prevent things from happening. And usually because we've developed relationships with insurances, they know that when we're doing this, we're doing them a favor. And so we don't have a lot of issues on getting those back off. But it is a pain sometimes. And sometimes they will just say, you know what, no, we're not going to give you anything. And what can you do? So we work with it as much as possible.
Yep.
Having had experience as a nurse, and then now I've heard a lot of complaints about insurance and the medical process, everything else getting harder and harder, more loopholes, more of a pain to try and get things. Is it as bad as people say?
It is getting bad.
Yeah.
It's getting bad because I think the biggest reason why we're having these issues is because in Arizona, we're one state that has probably more HMOs than most places do. A lot of places, they have maybe 1 or 2 insurances, and that's how it used to be. You'd have Blue Cross or United Healthcare or Medicare. Now in Arizona, we have so many HMOs that's making it very, very hard because we're having to go through all these hoops to be able to get this authorized. So yes, it is making it more difficult, but I can see why they're doing that because they're trying to weed out the people that aren't given the care they're supposed to. And so, like I said, with the insurances, we've developed a relationship. So they'll usually, okay, fine, we'll give you this. But if we didn't, what's going to happen? So HMOs, what's your thoughts, Anthony, on HMOs?
Yeah, we've run into a lot of, it's almost like Rebecca was saying, there's so many different plans that we can't just say, oh, do you take Blue Cross Blue Shield? It's let me look to see exactly which plan they are with Blue Cross Blue Shield before we can tell you if we're in network or not even. And so it means us going on, either calling our rep or getting on the website to see. And so it delays the process a little bit. And like Rebecca was saying, it would be much nicer and easier if there were less plans, more consistent plans. Because not only is it an in-network piece, but is it a, wait a minute now, you're in-network, but there's a $20 pay each visit. And it gets a little more complicated that way. So, yeah, to answer your question, yeah, it is getting more complicated as healthcare continues.
Well, it's because every January there's about 3 or 4 new insurances that roll up, and they'll be there for this year, and then next year it goes to something different. And even like with some of the insurances, like he said, there's 50 to 100 Blue Cross Blue Shield plans. Who knows if you're in it or not? Yeah, we're contracted, but is it one of the 50 that we're contracted with, or is it one of the 50 that we're not contracted with?
It's hard to keep up.
It's very hard to keep up. Yeah.
Mm-hmm.
What does home health look like for someone who is in like a residential assisted living versus in their own home?
So home health, if they're in a residential, so usually it would be different levels. Some of them have where it's included for like the skilled piece to where they have nurses or LPNs doing that in like a SNF or something like that. But then some of them, they literally only have either med techs or caregivers. A med tech can pass pills. A caregiver can take them to the bathroom. And so they're really lacking on, so if, let's say that they are getting weak and they can't get to the toilet, they might fall. Some of the places, the biggest places where adults or geriatric adults are hurt or die is in the bathroom. And so they don't have that. And I think we need to just educate them that sometimes they think if they live in an assisted living where they have the caregivers and the med techs that they can't get home health. It's a very, very, very same thing. We're going to treat that the same as if they were in their own house. So there's not going to be anything different. The only thing that would be different is if they do have med techs, the med tech is still going to be the one passing the med. So we won't do the Medi reset. But besides that, the therapist going to the living place, the OTs, everybody's going to go there just like it was in their own.
All the same
personal.
services.
Mm-hmm.
Okay.
Yep.
For someone who maybe is not in Maricopa or Pinal County or soon to be Gila County, what do you recommend when someone's looking for a home health company? Do they have any choice, or is it based on what their insured tells them to do?
So whatever facility they're being discharged from, legally that facility has to give them at least three choices to choose from. And normally those are choices that facility has dealt with prior. And a lot of the times the facilities, obviously, they don't want, when you're getting discharged from the hospital, the last thing they want to do is have you come back again. So ideally, that facility would want to give you the best that they've experienced working with. And so, you don't think you have to go find it always on your own. You should always have options from that case manager that should be giving you those options of places that would be available.
And if they don't do that, we have a lot of patients that do their due diligence. They've called, they've looked around, they've asked friends, and I mean, probably half our referrals are self-referrals. And so people telling them, or different places that we've already visited, or other places we've had patients, they're self-referrals. And so we get a lot of those. And I mean,
is that word of mouth or like Google searches?
Word of mouth or Google search. A lot of them is word of mouth. Like they say, okay, you need to go here. This is where you have to go. And so, I mean, we have a lot of patients where they've called up and said, we have to have you. And so, of course, we take care of them. But it's nice because a lot of the ones that we're getting are referrals from our patients. And that makes you feel good when you're getting all these referrals without having to really
work for it that much.
Well, you're working for it. We're just giving the care people deserve. And so
we've actually been approached by insurance companies saying, we're getting a lot of call from our patients in your area requesting your services. We'd like to have you come and network with us. And so that really makes us feel good because, to Rebecca's point, that means that our patients are so thankful for what they have, and that they're passing that information off to their friends too. And their friends are actually taking the time to call up their insurance company, and we all know how long you wait on hold with insurance companies, to say, hey, I really want to be with Stokes Home Health Care. And that says a lot about our providers and the level of care they give.
Yeah, absolutely. It's a testament to that level of care. Is there anything else that we haven't covered that you find yourself explaining to families or loved ones who are looking for home health services that we haven't touched on yet?
I mean, there's a lot of stuff, I guess, that you could go into, but the biggest thing is to be aware of the benefits that you do have. And if you don't know, reach out and find someone that can give you the answers. And don't always take what someone tells you at 100%. Because a lot of people have their own ulterior motives behind it all, and they're doing it for the wrong reason. And there's a lot of companies out there, and when you're medical, if you don't have the right heart, you might as well get out of it. Because people are going to see through the facade, and they're going to see that you're not genuine, and that's going to come back and kick you in the butt. So make sure you have someone that cares, and that's really going to, if they don't know the answer, and things are changing all the time, I'm going to respect someone that comes to me and says, you know what, this patient asked me this question and I didn't have the answer, so I'm calling, or I'm looking to see what I can get for that answer to the question. And I think that goes a long ways, and it learns respect. So just don't ask questions. It's your health. If it's not just your health, it's your loved one, it's your kids, it's your, if parents, mom, whoever it is they rely upon you to do your due diligence to make sure that they're taken care of. And so just make sure, and then hold people accountable. Hold them accountable for, if they said they're going to do something, hold them accountable for what they said they were going to do, and just really, really check the company out to make sure they're reputable.
Yep. And to piggyback on what Rebecca just said, as the caregiver for a loved one, you're the one who has their best interest in mind. Make sure that the home health care or hospice company that you find has that same point of view and has that same interest, because that's going to give your loved one the best level of care.
One thing I do want to, there's a lot of the advantage plans in NGS, and Medicare is trying to approve so they can have more hours of caregivers in their home. Some of the advantage plans have already taken a hold of that, and so they'll offer 30 hours of paid caregivers. But it comes at, they have to be Medicare qualified. If they're not certified through Medicare, they will pay zero. Mm-hmm. So a lot of these caregiving companies that are just all self-pay, it's because they haven't gone through the rigorous process to make sure that you are compliant, that you're going by federal guidelines, and that you do all these other things to be able to stay certified. And so make sure it's just not a caregiver. A lot of people are like, oh, well, you have nurses, you have physical therapists. Yes, we have all this, and your insurance pays for it. So make sure you find somebody that's actually a real facility,
Medicare certified,
and that's gonna, I mean, all in all, you're gonna get the best care for your loved one, and it's going to come at a lower price. And when with aging, it gets expensive.
Yep.
So, yeah.
Great, Rebecca and Anthony, thank you for your time today. What's the best way for people to find Stokes? How are they getting a hold of you?
So we have if you need to reach us and reach out for a self-referral, you can reach us on our website phone number to call is, if you need referrals or if you need guidance for anything, give us a call at 480-625-3303, or you can fax us at 480-625-3513, and our faxes are being watched 24 hours a day. Our phone calls, we take them 24 hours a day. And anyone that comes on with service with us, they have a nurse at their fingertips 24 hours a day. So I think that's probably what sets us apart. And then the website is
StokesHHCH.com, homehealthcarehospice.com.
See? But yeah, no, I mean, the biggest thing is to make sure that they can get a hold of us. They have us once it's easy. So anything else, Anthony?
The best way I would say to get a hold of us is speak to the case manager, caseworker that's working on your loved one's care, and let them know that you want to be taken care of by Stokes Home Healthcare.
Yeah, that's it.
Awesome.